I'm very pleased to introduce Dr. Berger, who's the chair of Vision Quest today. And so this is your chance to ask any questions that might be on your mind about AMD.
Thank you, Mary. This is a great opportunity for me. I see many familiar faces, so many of my patients are here, and unfortunately, I know I don't always have time to answer all your questions. So this is it. You got me for 40 minutes. Take advantage. I'm happy to answer any questions on anything. I know Mary specifically said AMD, but any other retinal diseases or any other eye problems that I have any information on, I'm happy to give you answers to. This session is totally informal. I have nothing prepared. I have a whole bunch of things I can talk about, and I will based on what you ask me. So the floor is open, and whoever asks a question, I'll repeat it, and we'll try and take it from there.
I have wet macular degeneration in both eyes, but it's much worse in the one eye. I can't determine faces and that kind of thing. Now, I've been taking injections for 5 years, but only in the badly affected eye. The other eye seems to be stable. Does that carry from one eye to the other? I mean, I'm not getting injections in the eye that's less affected.
Okay, so I think the question is, and correct me if I've misinterpreted it at all, is that you have wet macular degeneration in both eyes. You continue to receive injections in one eye. You've had injections in the other eye, or you've never had?
No.
Okay. So let me do a very brief overview of macular degeneration. I know you've heard it several times today already, but let me go over how things progress, and then we'll get specifically to your question. So macular degeneration is an aging process. I think you've heard before that it's basically, it's almost like getting wrinkles. It's not wrinkles, but it's like getting wrinkles or gray hair. And you develop little weak spots or deposits at the back of your eye, and these deposits, when they're just the little deposits, the analogy I use is if you've ever had under padding under a rug, imagine the under padding having little pebbles or little stones in it. And that's exactly what it is. These little pebbles, or drusen they're called, are under the retina, and so your retina over top works reasonably well, but it's a little bit corrugated or goes up and down and has bumps. So people with just the dry form can get a little bit of waviness or a little bit of distortion or a little bit of blurring. That's the dry form. That's the precursor or the form that everybody would have at the beginning, and then they go on to develop the wet form. These little pebbles or stones also weaken the wall of the eye, and when they weaken the eye, sometimes the blood vessels grow through, and that's when we call it the wet form. So it's called wet because there's actually fluid underneath the retina, and it's either clear fluid that's leaked out of your blood vessels or blood that's leaked out of your blood vessels. And in the old days, we didn't have any treatments that worked really well. We would blast the blood vessels with a laser, but it would leave a big scar, and wherever that scar was, and it was usually close to the middle, you would have a blind spot right there. The nice thing about the injection therapies that we have now is these injections actually make the little abnormal blood vessels and the fluid or blood that's back there reabsorb or go away. And so then the carpet can be nice and smooth again, although it'll still have the little pebbles. So these new treatments, the anti-VEGF injections, Lucentis or Avastin or Eylea, whichever drug you're receiving, all work very well, but everybody responds to them differently. So if you're saying you have wet macular degeneration in both eyes, most of the studies have shown that the best visual outcomes are in people having more than just 3 monthly injections, literally having continuous injections for the rest of their life. Some people respond well enough that we can stretch the intervals. Instead of doing every 4 weeks, we can do it every 5 weeks or 6 weeks or 7 weeks or 3 months or 6 months. And the very rare person, we can stop and observe them. The danger or the concern with stopping is if in the future, 6 months or a year or 18 months later, it starts to bleed or leak again, you will, in that eye, you'll notice the vision being blurry, and sometimes restarting the treatment, we can't get you dry again and can't get you back to where you've been. So, you know, why do they keep injecting your bad eye if it doesn't see very well? Well, first of all, you have the option of telling your doctor you don't want to keep having the injections. But when he or she stops the injections, if the fluid comes back or if it starts to bleed more, your vision might decrease, and they may never be able to get you back to where you are now. Even if it's not very good, it's at this level, and you don't want it to get down to this level. In your second eye, which has wet but isn't receiving injections, you're one of the fortunate few. in that it's probably not actively wet. It probably was wet, but is dried up sort of and not progressing. And so hopefully you'll never need treatments in your other eye.
Yes, genetically speaking, I know that mine comes from my mother. Now, is it passed more through from female to female? Because I have 2 sons, and I have a 14-year-old granddaughter who everybody says is my clone in the sense she's identical to any pictures of me. So could there be a propensity for my 2 sons or this granddaughter to develop it?
So we know a bunch about the genetics of macular degeneration. We don't totally understand it. Otherwise, we'd be farther ahead in terms of treating and potentially curing the disease. So don't completely blame your mother. It's because it's just as possible that your father had some of the genes. So we all have a DNA sequence in our body. We all have our own pre-programmed clock and map, and there's a million different little tidbits of information that basically lead to what we look like, what we talk like, what we act like, etc. So macular degeneration, so far we've isolated about 12 or 15 different genes that are involved in macular degeneration. There's 2, one's called CFH and the other's called ARMS2, and they're 2 different genes that seem to be, I'm not going to say the most important, but seem to be the most likely to be associated. So if you have both of these genes and they're both positive, then yes, it's likely that you'll manifest macular degeneration. So there is now already genetic testing that you can do. And if you're thinking of your daughters or your granddaughter or whatever, there is a genetic test that they can do. And that genetic test looks at these 12 or 14 different areas of your DNA sequence and sees whether you're positive or negative for these genes, and actually gives you a rough statistical probability whether you are or aren't going to develop macular degeneration. Again, the phenotype or the expression of the macular degeneration doesn't come on till your 40s, 50s, 60s, 70s. So the only sort of reason, and a lot of people, most people aren't getting the genetic test, number 1, because it's not covered by OHIP, and number 2, because they say, okay, well, what am I going to do with it, even if I know it? So if my parents both had bad macular degeneration, then yes, I know right off the bat there certainly is a chance that I might have macular degeneration. I would want to do the genetic test. And again, this is the genetic test in 2014. More and more discoveries are occurring all the time, and I'm sure 2 years from now and 6 years from now we'll be a little more accurately able to diagnose. I personally would want to know whether I'm high risk or low risk, because if I was high risk, I do as much traveling and all the things that I want to see. I would probably, it's philosophical, but I'd probably want to retire earlier. I'd probably want to do all the things that I want to make sure I can while I can see earlier, knowing that when I'm significantly older, I have a higher likelihood of developing macular degeneration. But it's philosophical, and a lot of people say, well, you don't have a cure for it anyway. What's the difference? Why do I really want to know or not? Well, we know from the AREDS studies that that we can decrease the risk of progression of disease by starting people on these vitamins. So again, it's another reason to consider vitamins, genetic testing. And the most recent interesting piece of information, but it's not completely corroborated yet, so I don't want to say I completely agree with this, but you know, the AREDS 1 study took about 10,000 patients, followed them over a period of about 10 years, and gave them a recipe of vitamin A, C, E, zinc, and copper. The decision as to what vitamins they would put in this cocktail was based on previous research that seemed to show zinc was of some benefit, vitamin A was of some benefit, C and E. So they put it all together. They took what they thought was the most appropriate dosages of each of these things, and they gave this same drug to a whole group of people with macular degeneration. And what they found was that overall, the group had about a 25% less rate of progression if they were on the vitamins than if they weren't on the vitamins. Well, everybody's different, and everybody, you know, yes, all these people had macular degeneration, but everybody's got a different genetic makeup. And the reality is probably some of these patients, overall the benefit was 25%, but probably some of these patients were helped 60%, and some of them may not have been helped at all, but we haven't been able to tease out who would be better with which drug. So this is all these things you hear about personalized medicine these days. There's now genetic testing, and I think there's someone talking about it outside there, and it's a test called, I think it's called VitaRisk, because a couple of recent papers showed that there's a small subgroup of patients with macular degeneration in whom our vitamins actually might increase their risk of developing wet AMD. So it's sort of scary, and I'm not telling you this to scare you, and I'm not even telling you this in that I don't want to tell you that I completely believe it yet, because it's only a couple of studies that have found this. And so we need a little more work done to sort of categorically prove it's the case. But if we show that it is the case, well, then we would probably recommend that everybody have this genetic test first. And 90% of people we will still put on vitamins, but that 10% in whom it might not work or it might actually be a detriment, we wouldn't advise vitamins, or we would advise vitamins without zinc, because zinc is the thing that for this subgroup doesn't do well. So where was your question? So your question was all about genetics and your kids and everybody going down forth. So it's not gender-based or gender-biased in any way. So whether it's daughters or sons makes no difference at all. Every one of your offspring has some risk, but it's impossible to tell whether it's high or low, and these newer genetic tests seem to be of some help in terms of stratifying who's at higher or lower risk. No, I think there's one called Macular Risk that I think is a couple of $100, and the VitaRisk is a little bit less than that. And I think they're available. Macular Risk came out about 5 years ago and was available for a while, but I haven't heard much about it yet. And again, I don't want you to think that I'm advocating that these tests are strictly necessary, because as I've described initially, the macular risk it's very much a personal philosophical question. Do you want to know if you're high risk or low risk, and how are you going to change things? Are you going to live your life any differently? It's not like we have a preventive medicine that we know works very well, because obviously if you were high risk and we knew we had a treatment that worked well, we would put all these people on this stuff from the day they're born or whenever they start on this, to give them a better chance of not developing the disease. But we're not certain about that yet. But it's interesting. It's very interesting. It's like, why do some people respond so well to medications and some don't? We know with Lucentis that I have some patients who I've been treating for 8 or 9 years who are doing reasonably well, but I'm still treating them every 4 or 5 weeks. And they're happy to come back for the treatment. I'm happy to administer the treatment because it's keeping them seeing. I've been in practice 25 years, and I can tell you the first 15 years, macular degeneration was a very depressing disease. Most patients I really couldn't help. I would tell them they wouldn't go completely blind, but all of them lost the ability to read. All of them lost the ability to drive. It was bad. So the fact that we have these treatments now that work so well is a wonderful thing. So we're continuing to do it. But some people, as I described earlier, some people need these drugs and will need them forever, and some people we can stretch it out to 8 weeks, 10 weeks, 3 months, 6 months, or even stop the drugs. And it would be great ahead of time if I could tell a patient when they first came in, based on a genetic test or some other test, I can tell you have a 95% chance that all I'll need to do is a couple of injections and 1 injection a year, and you'll be fine for the next 10 years. And it wouldn't be so fine, but I would love to be able to tell a patient, listen, I'm really sorry, but you need to know ahead of time that this treatment I'm going to be giving you every month for the next 5 or 10 years, and I think there's a good chance it's going to work, but you're going to need it every month. If you're not willing to commit to that, just be prepared that you're going to end up losing vision. We just don't have enough information to be able to say that to everybody. So our treatment protocols are designed, we do what we need to do, and then it's part of the art of medicine is that we sort of see how people respond and can tailor our treatment to each individual over time. Great question. The question is, why are people with light-colored irises, blue eyes and green eyes, more at risk of macular degeneration? I wish I had a great answer. We don't really know. It's the type of thing that, again, we do population-based studies looking at patients who get macular degeneration. If you take 10,000 patients from a certain population, you'll see that more of them than the average population have lighter color irises. Could be related to ultraviolet light getting through the irises. Again, lighter irises more of the light gets to the back of the eye than a dark iris. If from the time you were born or when you were young you wore a brown contact lens, so it literally blocks some of that light, that study will never be done. We'll never know for sure, but it probably has a little bit to do with that. And then it's just, again, blue-eyed people have certain genetics and brown-eyed people have slightly different genetics. So I don't have a great answer for you. Okay, so I'm going to repeat the questions. I'm not sure I heard them right, so tell me if I'm hearing it right. The first question was, can anything be done once an eye reaches a stage where they have a scar from macular degeneration? Okay, that's the first question. The second question is, what about stem cells? Okay, so again, I think if you were in any of the talks this morning, they talked about laser. So what laser did, again, imagine a driveway and you see one weed coming up through the interlocking pavements, and that's close to the middle of your vision. Well, now we have these drugs we can inject, which is like spraying weed spray, and the weeds just melt away. Not a problem. Nothing bad happens to the driveway. What laser was, it was a light energy causing a thermal reaction or a burn at the back of the eye, which could burn and damage the blood vessel, but would leave a crater or a hole in your driveway. So for a laser scar, at this time, there's nothing we can do to reverse or make a laser scar see any better, because the laser scar, we damage the area under the retina, and it thereafter damages the overlying area. So those cells in the middle of the retina that were damaged with the laser, we can't fix. So what about stem cells? So stem cell is as I described a little bit earlier, is the holy grail. A stem cell, you know, when we're all born, it's the sperm fertilizes the egg. It's a two-celled structure. It divides into a four-celled structure to a 16. It just keeps multiplying, and suddenly there's a body. And as you can imagine, some of those cells became skin. Some of the cells became bones. Some of the cells became brains. Some of them became retina. So a stem cell is a cell that has the potential to differentiate or develop into anything. So stem cells hold hope, because right now we can't regrow retina cells. We can't grow new retina cells. Well, if we could somehow harvest stem cells and cause them to differentiate into retinal cells, we might be able to repopulate that scar or apply stem cells to an area where the retina could regrow, and maybe those retinal cells could hook back up to the optic nerve and get to the occipital cortex in the brain, and you'd be able to see again. So stem cell research has come a long way in the last little while. Stem cell transplantation is used in multiple myeloma and a variety of blood cancer type diseases. And stem cell research has moved a fair amount in the field of retinal disease as well. There was a study that was just completed where they were implanting stem cells under the retina, directly injecting them under the retina, and I think it was centered in a center in Los Angeles, and I think they did about 25 patients. And again, these are early stage studies, so they first grow the stem cells into what's called retinal pigment epithelial cells, which are retinal cells. They've grown them in a tissue culture, and then they inject them under the retina. And what they found so far is that I think about 90% of the time at 6 months, the cells were still there and still working. And I think about half the patients felt they had a slight improvement in vision. But this is still very, very preliminary work. I think it's very promising. I'm not going to give you a time frame. I don't know if it's going to be 5 years or 10 years, or if we'll ever get to a point where we can regrow organs and regrow a new retina. But stem cell certainly is one of the areas where we're most focused on focusing our research dollars and our research efforts, because it offers the promise of potentially regrowing damaged nerve cells. Just like when people get spinal cord injuries or certain brain injuries, nerve tissue, unlike if you cut your skin and you take a piece of skin off, it will regrow. Most of the organs have the capability of regrowing or some sort of regeneration. Nerve tissue in general, and retina's nerve tissue, doesn't have that potential. So stem cells offer hope, but we're getting there. There's nothing ready for prime time yet. So it's interesting. The whole area of nutritional therapy and vitamin therapy is not as regulated as other medicines. So, you know, we can go and buy bottles and bottles of lutein or vitamin A, and most things, if taken in significant excess of the recommended daily allowance, can cause harm. We know that there is such a thing as vitamin A toxicity. I've not heard of, or I don't know of any specific damage from taking too much lutein, but it's clear from the studies that were done both in the AREDS and in other large cohort studies that there's sort of a ceiling effect. Over a certain effect, it either doesn't get absorbed properly and you excrete it one way or another. And I would caution against, if a little is good, a lot is better, just like I would say the same thing for any drug. So, I would try and stick as much as possible to the recommended daily allowance for lutein. But I don't know of any specific syndromes where if you take 3 times as much, you're going to have kidney damage or liver damage or anything else. Right. So I think the question, well, I'll repeat it a little bit, but the main thing is there anything, if somebody tells me that I have a scar or maybe the early stages of macular degeneration, is there anything I can do to slow it down or stop it from occurring? The only modifiable risk factor, so the only risk factor we have any control over of the things you discussed, can't change your eye color, but you can stop smoking. And unfortunately, I mean, the risk factors involved with macular degeneration progressive are very much like risk factors involved with cardiovascular health, stroke, heart attack, and all the rest of it. And the increased risk in smokers is somewhere between 6 and 12 times of developing progressive macular degeneration. So, definitely I would strongly recommend, if you can, to stop smoking, because I think in the long run, it'll decrease the rate of progression and the risk of progression. As far as whether the scar at the back of the eye means you have macular degeneration or not, have you seen a retina specialist or an ophthalmologist? Okay, so, if two things. First of all, your ophthalmologist probably will follow you over time. If your scar is not changing at all over time, then it may have been caused by something completely unrelated to macular degeneration. And if your ophthalmologist isn't sure, I don't blame you for wanting to know. Suggest to your ophthalmologist that he either take a photograph of your eye and show it to a retina specialist, or that he refer you to a retina specialist. And hopefully the retina specialist can answer your question.
Thank you very much, Dr. Berger.
Sure.
I have a rather simple question, and at least it's not technical. In one eye, I have wet, and the other eye is dry. And I'm neglectful in that I don't wear sunglasses as often as I should. What happens, for instance, if I wear sunglasses, the darkness decreases my vision by quite an amount, and so I'm reluctant. Like, for instance, if I drive a car, if I put dark sunglasses on, I can't see the dashboard and I can't see the speedometer. And so I'm between a rock and a hard place in using sunglasses, realizing I should, and yet they limit my vision just as a dark room does.
So I hope to extricate you from that dark spot between the rock and the hard place. So where did we ever come up with this thing about sunglasses decreasing the likelihood of macular degeneration? Most of it comes from long-term population studies looking at who gets and who doesn't get macular degeneration, and then figuring out from there that it's probably related to ultraviolet and sun exposure. So some of these studies were looking at people from the same population, some of who were fishermen, who were always out on the water, who were always exposed to a lot of sunlight, versus people from the same community, the same age group, same group of general systemic diseases, who worked in offices or worked inside where they wouldn't have as much light exposure. And what we found overall was the group who had more prominent light exposure as part of their daily activities, they had a higher risk of developing macular degeneration. What was taken from that is probably if you had less UV exposure, you would ultimately have less macular degeneration. Probably, if someone is prone to develop macular degeneration, probably they need to start wearing glasses from when they're 3 years old. So the reality is, it's just my personal opinion, by the time you're 60 or 70 or 75, whether you wear the sunglasses or whether you won't wear the sunglasses probably will make absolutely no difference in your amount of progression of your macular degeneration. And as you perfectly described, people with progressive dry or wet macular degeneration have blurrier vision, have decreased contrast sensitivity, need more light. If you put sunglasses on, Your light, the light that's getting to your retina is less, your contrast is less, and you've just described what the problem is. It's harder to see things. So my advice would be, I don't think you should worry at all that you're sealing your fate or limiting your lifespan of good vision or reasonable vision by not wearing sunglasses.
Hello. I want to know why my vision is all peripheral only, that I am taking injections. If it's going to improve my eyesight, how can it do that? If it's just I can't have front vision?
Okay, so let me explain a little bit about macular degeneration. So the retina is a thin layer that lines the entire inside of your eye. The area that's most critical for being able to recognize face and being able to read is the central area of the retina. That area is called the macula. So if you think of a map of Canada and you think of the retina as the whole map of Canada, the province of Ontario, at least in my opinion, the center of the universe, or the center of Canada, the province of Ontario would be the macula. So anybody who has any macular disease, macular degeneration, Stargardt's disease, diabetic macular swelling, anything that damages or in any way impairs the macula will leave you with difficulty seeing centrally, but it doesn't damage, and macular degeneration in general doesn't damage your peripheral vision at all. So what you've described is unfortunately a typical description for somebody who has a fair amount of central macular damage from macular degeneration or other disease. You retain your peripheral vision, but your central vision is poor. If you're receiving injections, I would imagine you're receiving injections because your doctor thinks that if he doesn't give the injections, he or she doesn't give the injections, the central damage will get worse with time. And so you'd have to speak to them to ask them, but probably there's a fair amount of damage already and the injections are being done to limit progression of that damage. But you should speak to them to try and get realistic expectations about whether they think you're going to be seeing better centrally or whether the goal of treatment and where they're at is preserving what you have.
Hello, yes. My father, sitting here, he has macular degeneration, and he's been seeing a specialist at Sunnybrook for many years now, and he was getting injections as well. Now, he did have peripheral vision for a while, and then about 2 months ago, he had a stroke. Now he's lost completely all his eyesight. Is there any way it will ever come back?
Okay, so I'll go through sort of the anatomic pathway, and then I'll try and answer your question about whether it can come back. So the eye is that little structure that we have in the front here. The lens and the cornea focuses images on the retina. If you think of a camera, the cornea and the lens are like the lens on the camera. The retina is like the film on a camera. Once images and light get focused on the retina, they then have to travel through a nerve, something called the optic nerve, that runs all the way back to a part of the brain called the occipital cortex at the back of your head. And that part of the brain is what does the conscious seeing. Okay, so in order to see, you need to have structures that are working all the way through. If you have brain damage in the part of the brain that's involved in seeing, you can have a totally healthy eye, totally healthy optic nerve, but you're not going to see anything because the brain can't process that information. If you have damage in the macula, but your nerve is fine and your brain is fine, you'll see, but you'll have a central blind spot. So what you've described sounds like he was receiving injections for his macular degeneration. And again, macular degeneration usually only affects your central vision. Very few people with macular degeneration lose their peripheral vision. If the macular degeneration process, the wet form, is progressive and doesn't respond to our injections, sometimes you can lose all vision, but that's really quite rare. But if on top of the retina damage, he's now had a stroke that's affected the occipital cortex, or the part of the brain either involved with seeing or the part of the brain through which the optic nerve gets back to that part of the brain, then that's explaining why he's having trouble seeing at all. You'd have to speak to his doctor to find out what the specifics about what he has and what he doesn't have. Certainly strokes and damage to the brain at this point in time, we can't really repair. Oftentimes, over time, those parts of the brain recover somewhat, but they don't usually recover fully. And again, it depends on the extent of the disease in the retina as far as what the doctor's expectations would be. So I'm giving you a qualified, we probably can't help him see better, but you absolutely have to speak to the doctor and ask for the specific reasons why he can't see at all. And they'll tell you whether there's something they can do.
You mentioned that hot laser is damaging the retina.
Yeah.
Before the injections appeared, I had a treatment called Visiodine with cold laser.
Yes.
Does that do the same kind of damage like a hot laser?
No, so it's a little bit different. So just in case you didn't hear the question, the sequence in my 25 years of life and in 25 years of being a retina specialist was for wet macular degeneration, way back when we did what's called thermal or hot laser, where we caused a scar at the back of the eye. It cauterized or damaged the blood vessel and made it shrivel up. Unfortunately, more than half the time the blood vessel just came back at the edge of the scar. But that was a treatment that always left a blind spot or damage where we did the laser. Following that, in about the year 2000, we started doing a treatment called photodynamic therapy with a drug called Visiodine. So this was a different way of treating it, and it held a lot of promise. And again, if I use the analogy of a weed coming through interlocking stones on a driveway, for Visiodine treatment or photodynamic therapy, we would do our tests, we would see where the abnormal blood vessel was leaking. We would inject a dye in an intravenous, either in your hand or in your elbow area. This drug would travel through the body. The drug didn't do anything on its own, but if you shined a specific wavelength of light, and this is this cold laser light you're talking about, which on its own also didn't cause any damage, but if we focused it right on the blood vessel with that drug coursing through it, the laser caused a chemical transformation of that drug to make it cause the blood vessel to shrivel up. So it was a very neat idea. We thought, well, isn't this amazing? We'll do this photodynamic therapy, the drug will shrivel up and the vision will get all better. The reality is, of all the patients who had, and this was a drug that would needed to be re-administered every 3 months, of all the people we did the treatment on, about 35% of people had a response, and probably about 2 or 3% of people had improvement in vision. So it wasn't very satisfying. It didn't work very well, and most people, despite us doing these treatments every 3 months, the vast majority of people, probably over 90% of people within a year and a half, lost any useful central vision. So by comparison, the transformation with anti-VEGFs or the injections we're doing now, like I said before, we had 2% of people having improvement in vision when we did Visiodine treatment or photodynamic therapy. We now have about 40 to 45% of people having improvement in vision back to a level where they can read or drive. Whereas in the past, you probably had about 30 or 35% of Visiodine people that we could stabilize. We can now stabilize over 90%. So the treatments are way, way, way better, but the treatments aren't 100%. And so if you had the Visiodine or the photodynamic therapy, the treatment may have worked reasonably well, but it didn't stop progression of the disease. And in all likelihood, because this was probably done many years ago, you probably have a scar now, and we can't eliminate the scar. If and when we can develop stem cells and regrow the retina, then there's some possibility we'll be able to get you seeing better.
Sorry, doctor, we have time for one more question.
Thank you. Is there any indication that this constant injection into the eye is causing scarring or damaging the sclera in any way?
So, fantastic question. I remember about 12 years ago going to a meeting, and we were told that we would have to start injecting drugs into people's eyes. And prior to that, the only time we injected drugs into the eyes were if people developed infection after eye surgery, we would inject a drug. It was a complicated process, and it worked half the time. The fact that we're here 10 years later and I'm injecting every month begs that question. Over time, isn't this drug going to damage the eye? So there's a couple things. First of all, amazingly, this drug is amazingly safe. I've been using it long enough now. I'm totally impressed with how safe and effective the drug is. In my opinion, the drug doesn't really cause damage in any way, shape, or form. But the underlying disease has a tendency to progress. So even if we keep giving the injections and the blood vessel stops leaking and we can keep the retina dry, what we're finding is over time, the atrophy or the thinning or the weakening of the cells progresses as people are getting older. So what they're finding in studies now is that despite the fact that we've kept the retina dry for 5 years, if we look at those patients' retinas now compared to 5 years ago, areas of the retina are weaker and probably permanently weakened. But there isn't very much option. So the main answer to your question is, my personal opinion is the drugs are amazingly safe, and I don't think they really cause damage at all. I think it's just progression of the disease. Now, the only little twist on that is some patients who get injections can develop glaucoma. And glaucoma is a disease where pressure in the eye causes damage to the nerve. And so your doctor, when he's checking each month, is looking to see if there's swelling or leaking, but is also going to be monitoring your pressure in the nerve at the back of the eye. And if suddenly he says, I need to put you on this drop, or I need to do this laser, or I need to send you to a glaucoma specialist, it's because not specifically the drug, but the act of doing lots of injections potentially can cause some collateral damage or side damage. Thank you very much.
Yeah, you are very wonderful doctor.
Thank you.
I thank you from my heart.
Thank you.